So there is another question from Dr. Aditya Gupta. Uh, in newly diagnosed diabetic condition, which are the safe OHA for anesthesia purposes?
Okay, so basically, when you're looking at a person going for surgery, most of the time we would like to use insulin during this situation. Any form of anesthesia required, any form of general anesthesia, we would try to stop OHA before that. On the day of surgery, stop the OHAs, use insulin perioperatively, and get them back to OHA later on. Now, this is what the general practice would be. But if you are looking at amongst the OHA, which are the safest ones, again, the DPP-4 inhibitors probably stand out there. SGLT2 inhibitors have a little problem in the sense that, whenever there is any form of sickness, you would like to avoid SGLT2 inhibitors because they have a risk of causing ketoacidosis, euglycemic ketoacidosis in this scenario. So, SGLT2 inhibitors to be avoided, SUs to be avoided because they can cause hypoglycemia. Metformin also, again, because if you're using contrast agents or if there's hypotension, there could be a problem. So I think again from that angle, DPP-4 inhibitors stand out as a good choice, and by and large we would like to put patient on insulin on the day of surgery and subsequently perioperative period, and although they may be managed with OHA prior to surgery.
From Dr. Chetan Gangane from Maharashtra, he talks about best possible treatment for A1C 10.
Now with A1C of 10%, so at a A1C of more than 9 or 9.5, we would think of using insulin, particularly if the patients are symptomatic, if they are losing weight, if they are feeling tired, weakness, and they are in a catabolic state. We would certainly try to use insulin in such situations. In those who are asymptomatic, sometimes you may use a triple combination, but I would certainly prefer to use insulin in such people for at least a short duration of time, and then put them on OHA later on, OADs later on.
And the other one is from Dr. Shruti from Delhi. She talks about, should the anti-diabetic medicine start at an A1C of 6.2?
I was highlighting the AAC guideline, the American Association of Clinical Endocrinology guideline, which was speaking about the starting A1C or the A1C at onset of diabetes in deciding which form of therapy is best suitable for them. For less than 6.5, most of the time you do not require any therapy. Metformin may be used if you have difficulty in terms of advising lifestyle measures and they are not able to follow lifestyle changes, then metformin may be considered there, but otherwise we would prefer to just advise them about lifestyle changes with the A1C of 6.2.
The next one is from Dr. Kaushik Shah from Maharashtra. He talks about, should we start metformin plus glimepiride combination immediately?
Metformin glimepiride combination is a very good combination, and as you've seen data about metformin being the first choice, and when the HbA1c is more than 1.5% above the target HbA1c, that is, if you want to keep the HbA1c at say 6.5 or 7 and you have somebody who has got HbA1c of 8 or 8.5, there you can think of a metformin glimepiride combination because it has got a durable action, it is very effective in glycemic control, and also the fact that it is safe from a point of not causing much of hypoglycemia, and also from the cardiovascular safety, as we have seen in the different trials that I have shown. The Carolina trial showed that the cardiovascular safety of glimepiride, and then we also have data on the different observational trials which have shown the cardiovascular safety of these molecules. So it can be used. The other option that you have, if you find that the patient is having symptoms of hypoglycemia at different times of the day, you should advise him about having their meals on time. And in spite of that, if the hypoglycemia is a problem, then use of any of the gliptins may be suitable if they are having hypoglycemia and they have a A1C of 8.5%.
About when to switch from an oral anti-diabetic drug to insulin.
That when you used optimal doses of 2 or 3 oral agents and the patient is still not at target HbA1c, then it's time to consider insulin. So most of the time we are thinking of adding insulin to the oral agents, unless we are dealing with a type 1 diabetes where we know that the oral anti-diabetic medications are not going to work. There we are thinking of only insulin. But in a patient with type 2 diabetes, certainly there is a role for oral anti-diabetic medications even when the person is on insulin. Particularly metformin can be continued because metformin addresses the insulin resistance, and thereby it reduces the requirement of insulin. And similarly, there is a school of thought that many people would even continue SUs, that is glimepiride, can be continued along with insulin because again it reduces the requirement of insulin, reduces the need of larger dose need for larger doses of insulin can be reduced by the use of metformin also in people with type 2 diabetes. So the typical way in which you would start insulin is that when the fasting is going up, only the fasting is high, we would think of using basal insulin. When the basal insulin alone is not enough, and if there is a significant postprandial hyperglycemia, we would like to then use in spite of oral anti-diabetic medications. If that is persisting, then you would try to add insulin, prandial insulins, but otherwise we could even go with a basal supported oral anti-diabetic therapy.
From Dr. Swati Jeevane, it talks about how to reverse or delay multi-organ derangement.
That is very important, which I was addressing initially by saying that we have data from the UKPDS study which typically looked at people who were followed up from the time they developed diabetes, and they were divided in two groups. One group which was intensively controlled, kept HbA1c of less than 7% over the 6 to 7 years of follow-up, and the other group which was less intensively controlled, their HbA1c is close to 8%. With that 1% difference in HbA1c, what we saw, there was a 30% reduction in most of the complications, the microvascular complications like neuropathy, retinopathy, and also a non-significant reduction in cardiovascular disease. And when these patients were followed up over a period of time, over another 10 years, what they found was those who were intensively controlled initially tended to have the benefit, tended to persist to have the benefit, saying that there is something called as a glycemic legacy, which means that if you are able to keep your patient at good glycemic control in the initial years, that is when he comes to you for the first time, if you are able to achieve that, he will tend to have a benefit which goes on for many years, maybe 20-30 years down the line also he will continue to have that benefit of that first few years of very good glycemic control. So this is something which is saying that by effectively addressing the management of diabetes early in the course of diabetes, you will be able to protect the person from all the long-term complications. And it goes without saying that apart from glycemic control, you should also look at the blood pressure, the lipid levels, advise them about smoking, and advise them to follow a good healthy diet and do exercise regularly, and that will all go in a long way in terms of reducing the risk of complications.